Hi, this is Dr. Sham, and we are going to talk about today the PVC, premature ventricular contraction. The premature ventricular contraction, as the name implies itself, it's a premature beat that's arising from the ventricles. That could be either from the right ventricle or from the left ventricle. So this lecture of ours that's will be we will be discussing about um, what the PVC is, how we're going to get to know that it's arising from the right ventricle or left ventricle, then its classification, the patterns, the causes, and what are the frequent PVCs. So first of all, what is the feature of a PVC? What when we call that it's a PVC? So if you look at this rhythm, this strip of ECG, so you can see that here these are the normal ventricular contractions. They're having a specific shape, specific pattern. While these two things, one over here, these are different from this normal one. Okay, if you look at that, so these are the PVCs. So if we look into this, that it is broader as compared to the normal one, the first thing. Then it is premature. The second thing is, okay, so if this is one ventricular contraction, the other is this one. The next one is supposed to come somewhere over here, but it comes earlier. This one comes earlier. Okay, let's remove that. So what's happening? So these premature ventricular contraction, they have broad QRS that is greater than 120 millisecond. So QRS greater than 120 milliseconds. The second thing we discussed is that premature, it occurs earlier than expected. Third thing is there's a discordant ST segment and T wave. You can see over here, the QRS is upright, T is ST is at the normal, okay, what it comes like. It's not depressed, and the T wave is upright. So these are actually concordant. Discordant is this QRS is up, ST is down, T wave is inverted. So this is called discordant ST segment and T wave changes. So that's the third feature. Okay, and then there is usually a full compensatory pause. This is a compensatory pause, okay, until the next normal beat is over there. So these are actually the feature of PVC. Broad QRS, it's premature, it occurs earlier than expected. There's a discordant ST and T changes, T wave, and usually it's a full compensatory pause. What happens is actually uh, the thing is that this premature ventricular contraction, it bypasses the His-Purkinje system and depolarizes the ventricles directly. Normally what happens is from the ST node it goes to the atria, it goes to the AV node, and then through bundle of His, right bundle branch and the left bundle branch. This is the normal pattern of current flowing through the heart. So this in the premature ventricular contraction, it doesn't follow this thing. So you will be having a focus in either the left ventricle or the right ventricle, and it directly depolarizes the ventricles. This disrupts actually the normal sequence of cardiac activation, leading to the asynchronous activation of two ventricles. Okay, if we talk about the causes, what could cause this premature ventricular contraction? It could be either ischemia, that is most important. Then simple things, anxiety, caffeine, okay. Then there's some drugs like beta agonist, sympathomimetics. These can cause that. Then some electrolyte disturbance, hypokalemia and hypomagnesemia can cause PVCs, and then ditch toxicity. So importantly, keep ischemia in your mind, because this is where you need to act and you can correct that. and low potassium and low magnesium. And then take a drug history, digoxin or any sympathomimetics, and then anxiety and the caffeine. Another next thing is the classification. The classification is that it could be unifocal, it could be multifocal. What do I mean by that is that unifocal means that they are originating from one point, so that they will be similar in shape. You see, these two are similar. So this is unifocal. Multifocal means that PVCs are originating from more than one point. So if you see this PVC over here, you can't see that exactly, but this shape is different than that of these two PVCs. So this is a multifocal PVCs. This means that these two are originating from one point, and this one over here, I can't see it correctly. Is there any way of I don't know. I can't show you over here, but like it is certainly, you can see that it is different from these two. So that is originating from a different point. So that these are multifocal PVCs. Then the next thing is the origin. Either they are originating from right ventricle, your PVCs are coming from right ventricle or left ventricle. How are you gonna find out that? So if you have to see a look at the lead V1. So if in the V1 you find LBB pattern. LBB pattern is in the V1 when you have deep S wave. So deep S wave in LBB, your V1 is having deep S wave. So if you find LBB pattern in V1, that will be originating from just opposite, like right ventricle. Okay, and if you find an RBB pattern in V1, in RBB there's a dominant R wave in V1, okay, RSR pattern. So it's a dominant R wave in V1, so that's RBB. So this means that your PVC is originating from the left ventricle. Okay, the next thing is that the patterns. Okay, here you can see the bigeminy, trigeminy, quadgeminy, couplets, triplets. We're gonna talk about that. So here you can see is a normal beat with a PVC, normal beat with the PVC, one PVC, one beat, normal beat, ventricular contraction. I mean, this is bigeminy. Okay, trigeminy means that there are two normal ventricular contractions and then a PVC. Quadgeminy means there are three normal ventricular contractions with a PVC. That's called quadgeminy. Okay, then the next thing is couplets. You see two PVCs coming together, couplets. This is called couplets. Then it can happen that the three PVCs are coming together. That is called triplets. The other names for the triplets is short bursts of the VT. When three PVCs come together, we call them short bursts of VT, or you can say non-sustained VT. Non-sustained VT is actually the PVCs, 3 to 30 PVCs coming consecutively together. So some people use the triplets, some use short bursts of VT, and some use non-sustained VT. So these are the different patterns of the PVCs. You can see. Another important thing is that when you need to worry about the PVCs, yeah, if they are coming in the ischemia, particularly, you should be worried about that. Then if these triplets are coming, okay, then there is another thing, what is frequent PVCs. So if you have 5 PVCs per minute, okay, or 10 to 30 PVCs per hour, these are called frequent PVCs. These frequent PVCs, they are problematic, particularly when a patient is having a long QT as well. If someone is having a long QT and is running the frequent PVCs, that's problematic because that can lead to the torsities, depointes, twisting around the points, polymorphic VT. because of the R on T phenomena. So if you don't know the R and T phenomena, just go to one of my videos that's about the QT interval. There I have explained how the long QT actually leads to the fatal arrhythmias. So this is about the PVCs. So always when you have PVCs, okay, what you can do is that it's multifocal or unifocal, where it's coming from right ventricle or left ventricle. Then what's the pattern? I need to begin look at when, particularly when there are triplets or what we call a short burst of VT. Then always you have to have ischemia at the back of your mind, the number one thing. Then any drugs, then electrolytes, decrease potassium, that's hypokalemia and hypomagnesemia, or the ditch toxicity. Keep in your mind. Thank you so very much.